What would be the sort of the main different modalities of hormonal treatment for ladies?
Okay, so the modalities that we talk about is we can say oral, so that's where you take a tablet. Then transdermal, that can be a cream that you apply. It can be a patch that you apply once a week, or it can be a gel that you rub into your skin.
So anything that comes through the skin.
Through the skin. And then we speak about mucosal. Usually that is where you use a suppository, either vaginally, and if you have other problems, rectally. And then also we're talking about implants, subcutaneous implants. That is a tube-like implant that they usually implant in the inner upper arm of the lady, specifically for menopausal.
So that is sort of a slow release system.
Slow release system as well, and then intramuscular injections as well. That is the other modality that we need to add.
And Mark, it's quite a lot of different modalities that we're talking about. What are the different levels of efficacy, or the reasons, maybe is a better question, for these different modes of delivery?
Well, Michael, if we talk about efficacy of them, you need to understand that if I apply something to the skin, it needs to get absorbed through the skin. So whatever this condition of the skin is, let's for instance say you have a compromised barrier function, your absorption is going to be as if you're putting it onto an open wound. So it's immediately exposed. The problem with that is it's still going to be metabolized. It gets absorbed into the bloodstream through the liver, and then it gets to where it needs to go. The same is true for oral medication. In the previous programs and in previous seasons, we spoke extensively about gut. When I swallow something, it goes into the stomach. Some of it gets absorbed through the stomach. Most of it passes through into your small intestine, where we absorb all our nutrients. And this is where we absorb most of our medications. If we have a compromised gut function, or if the acid level in the stomach and in the gut is slightly off, your medication will be absorbed differently. When we absorb things, they still pass through the liver, and most of medications have half of their active ingredients metabolized with the first bypass, and then the kidneys also play a role. I prefer in my practice to use an injectable if I can, for the simple reason I can control the dose much more accurately. I also prefer to use a short-acting over a long-acting drug, for the simple reason if we use a long-acting drug, it's in. I can't do anything about it. With a shorter acting drug, I can control the dose more accurately and more frequently.
And adjust the level.
Absolutely. The same is true for an implant. If we give an implant, that implant stays in. It leaches whatever active substance it's supposed to into the surrounding tissue. But that can itself create some inflammatory reactions, etc., etc. So
can I just interject there? Also with the implants, if it's in, it's in. And you don't know as a patient how you're going to react to that typically.
So you don't get a test phase?
No, you don't get a test phase. It's there, and it secretes certain hormones that you may need, but you won't know how you are going to benefit from it, or how you're going to react. What is the side effects for you as a person?
We spoke about that in last week's program, where we spoke about all medications have effects.
Yes.
But they're accompanied by side effects. Side effect profile is, if you open that pamphlet that comes with your medication, there's a myriad of things that it gives. So these are in the trials that they've done. One patient might have had an upset tummy from licking the carpet, but during the trial,
part of it.
It said that this can cause an upset stomach. As we said last week, when you embark on a regimen of treatment, you need to do so in conjunction with your practitioner, but with the knowledge to make an informed decision.
Correct. Yeah.
And then at least Mark mentioned that he prefers an injectable where possible. Is it something that would be dependent on the practitioner more, or does the patient have a say to say, look, I don't want to have an implant, I'd rather do a topical cream, or I don't want an injection, I'd rather have an implant? How would you then just advise them and say, look, you can have it either way, but we would suggest this because of X, Y, and Z?
Yeah, and in our practice, we really discuss the different treatment modalities. Okay, this is available, you can take it orally, or this is available, it's a patch, or I prefer, and I will usually tell them, I prefer the dermals for women, females, hormones.
So when we look at safety
Yes.
of hormone treatments, different treatment modalities and different ways of administration can have and do have different risk profiles.
Okay.
So when we think about hormone treatment for menopause specifically, depending on whether you still have your uterus or not, will determine whether you are getting a estrogen only preparation or whether you are getting a combination treatment with progesterone and estrogen. If we look at comorbidities that go hand in hand, let's say you have a history of a deep vein thrombosis or a pulmonary embolus or a stroke. The route in which you are going to take your treatment will differ. There's a lower incidence of DVTs, stroke, with transdermal preparations.
Right.
As we said, we decrease the risk of something like breast cancer with an estrogen-only preparation, but we can only give an estrogen-only preparation for a woman that does not have a uterus anymore.
Okay.
And then we can, what also needs to be taken into consideration is when we work on hormones, they have cycles. So are we going to give a continuous treatment at the same dose, or are we doing a cycle? For instance, from day 1 to day 21, we give estrogen, and from day 21 to day 28, we give progesterone or a combination of it.
Okay.
So all of that is determined by your current medical state, the comorbidities you have. I think lifestyle here plays an incredibly big role because you need to become adherent to this medication release, and I think a lot of our patients struggle specifically with that.
I agree, and that is one important factor, is you need to understand what will work for that specific patient.
Yes.
For instance, lots of patients will tell you, I don't like taking tablets. And I mean, most of the hormonal treatments out there is in a tablet form. So you need to adapt to what their needs are, as well as what you know is safe and beneficial for them.
And then at least one question that we haven't sort of touched on is the question of, is hormonal therapy for everybody, or are certain people sort of not quite in the right condition, or certain comorbidities that would be adverse in terms of going into a hormonal treatment process?
Absolutely. I think Mark must help me with this one. But yes, absolutely. Certain patients we will not even consider, for instance, giving estrogen.
Yes.
But there's other hormones that we can help them with.
Or other ways in which
Or
you can
other
treat the
ways,
patient.
yeah.
Okay.
Michael, so not everyone is suitable to hormone replacement therapy. For instance, patients with active cancer, breast cancer for instance, that is dependent on or related to hormones.
Right.
Your BRCA2 and 3 type genetic mutations. We will be very careful to give these patients hormone treatment. What usually happens with them is they have a surgical oophorectomy. We go and take the ovaries out, but we can then, after a certain period of time, give hormone optimization therapy if their menopausal symptoms, which is a direct cause of the surgery, becomes severe.
Okay, okay.
Again, I want to emphasize that embarking on a journey of any medication, but especially hormone-related treatments, you have to spend time with your doctor.
Yeah.
You yourself have to understand the condition, the benefits versus the risk. Benefit of treating it, how it will improve your quality of life. The risk involved in that, and as we said last time, risk does not mean you're going to get something. It's the possibility of being in an accident increases.
Absolutely.
Lifestyle plays a very big role. A lot of what we do will involve lifestyle changes. If the patient doesn't buy into that, and if the patient is not on board and in control of these changes, they are not only not compliant with medication, but they're definitely not adherent. Because to adhere, you are involved. So when you do this, get involved. You are the one that's involved and in control of this, not your practitioner.
Okay.
And also there you will have a say in the modality, the treatment
Yes, how you get
modality,
it.
how to get it, yes.
Elise, Mark, thank you so much
Thank
once
you
again.
so
Such
much.
great information.